Thank you, sir. Thank you for kind introduction. Also, let me thank Dr. Vijayakumar, sir, for inviting me to this session and also being kind enough to share some of his slides. Actually, he had given this talk in great detail in RSSDA Kerala chapter, and that is where I think we got this inspiration to give a talk on this particular topic. And my topic is actually in contrast to what you might have heard yesterday and what talks I generally give. This is a very simple and clinically oriented talk. So the question we are trying to answer today is how to deal with somebody who has difficult to control type 2 diabetes. I don't have any conflicts of interest relevant to this talk. And we all know why this topic is important because this is data from the ICMR INDIAB study, and we find that even if you take a general cross-section of people with diabetes, most of whom have type 2 diabetes, the level of glycemic control in India is abysmally poor, be it in primary setting, secondary setting, or tertiary setting. Only around a third of individuals have their HbA1c levels below 7, which is the ballpark figure considered as suggestive of good control. Now, we can't call all of these individuals difficult to control for the simple reason that many of them may not have even tried to control the diabetes. Many of them may just be wandering around the cross-section study, we caught hold of them and we find that their sugars are out of control. But then how do we define difficult to control diabetes? It's defined, this is again a rule of thumb or a ballpark definition. Somebody who has got poor glycemic control, HbA1c above 8%, in spite of taking 3 or more oral anti-diabetic agents or non-insulin anti-diabetic agents with or without insulin. And most often in clinical practice, we find that this is associated with insulin resistance, although as you will see, some of these cases also have profound insulin deficiency. So what should be our approach when we are faced with such a patient? The first thing to see is the diagnosis correct? We talked about difficult to control type 2 diabetes. Is it really type 2 diabetes? That's the first question we need to answer. If we have a diagnosis of type 2 diabetes, is the treatment that we are giving to this patient apt or appropriate for the pathophysiology of that particular patient? And the third question obviously would be, is the patient adhering to the treatment, which I feel is the most important question to be answered. Now, does the patient actually have type 2 diabetes? Now, these are some of the mimics of type 2 diabetes which can happen in clinical practice. So we should consider type 1 diabetes, which traditionally used to be called LADA, now called slowly progressing immune-mediated diabetes of adults. We have to consider some of the monogenic diabetes syndromes, pancreatic or type 3 diabetes, type 3C diabetes, diabetes secondary to endocrinopathies, and drug-induced diabetes. And we'll go into each of these in some detail. Now, what do you mean by LADA or slowly progressing immune-mediated diabetes of adults? Now, this is nothing but type 1 diabetes, which comes later in life and which progresses slowly such that you may mistake it for type 2 diabetes. But the differentiating feature here is that these individuals tend to require insulin or to become insulin dependent within 6 to 8 months of diagnosis, unlike type 2, which becomes insulin requiring only after a few years of diagnosis. And when you look in further detail, you will find that they do not have a strong family history of diabetes. They do not have any features of insulin resistance such as obesity, acanthosis nigricans, etc., etc. The C-peptide will be disproportionately poor if you have the facility to check it, and they will be positive for one or more of the pancreatic autoantibodies. And it's very important to make this diagnosis because if you fail to make the diagnosis and don't put them on insulin, they may end up in diabetic ketoacidosis because they are type 1 diabetes. Monogenic diabetes, most cases monogenic diabetes or MODI does not present as difficult to control diabetes. Because for most of these cases, the treatment of choice is sulfonylurea, and that too low dose sulfonylurea. And in India, fortunately, we have a situation where if metformin doesn't work, most of us will put these people on sulfonylurea. So even if you don't have an accurate diagnosis, they end up getting the right treatment by default. So generally, monogenic diabetes, MODI1, MODI3, HNF1 alpha, HNF4 alpha does not represent a phenotype of difficult to control diabetes. But there are some other rarer syndromic forms of monogenic diabetes which require insulin right from the time of diagnosis, like Wolfram syndrome and Walcott-Allison. You may think that is easy to diagnose, but remember that many of these cases, diabetes may be the first manifestation before all the syndromic features present. So you may find it difficult to diagnose them when they only have diabetes as a presenting feature. And these are some of the clinical clues for MODI. young age at onset, 3-generation autosomal dominant transmission, low frequency of obesity and other signs of insulin resistance, presence of multi-system involvement. And there are also individuals who have monogenic defects of insulin action. These are some of the syndromes of severe insulin resistance. Somebody who is non-obese presenting with features of insulin resistance like acanthosis and fatty liver and PCOS and so on, you need to consider these situations. FCPD, still not uncommon in India. It has become rarer with the passing years, but it is still seen occasionally. Now, this is nothing but a pancreatic form of diabetes secondary to non-alcoholic chronic calcific pancreatitis. Patient comes with recurrent abdominal pain in the first decade, exocrine pancreatic insufficiency in the second decade, followed by diabetes in the third decade of life. The diabetes is usually severe, brittle. In spite of severe hyperglycemia, the patient will not have ketosis. And the diagnosis is made by imaging studies, either a plain X-ray of the abdomen or an ultrasound in skilled hands or a CT or an MRI. These people mostly need insulin. It is better to avoid incretin-based therapies because they increase the risk of pancreatitis. Most of them need insulin, and the most dreaded complication in this case is the risk of pancreatic carcinoma. Then we have various endocrinopathies. So many endocrinopathies we can list if you know the counter-regulatory hormones: acromegaly, glucagonoma, hyperthyroidism, pheochromocytoma, Cushing's. Generally, if you think about them and if you look for them, you will find them. If you don't look for them, you will not find them. And it's of interest that there has now been a recent study showing that even subclinical hypercortisolism, florid Cushing's, there is no price for diagnosing because anyone can diagnose florid Cushing's. But even subclinical hypercortisolism without any of the features of Cushing's can lead to difficult to control diabetes. And this is known as the Catalyst study, which was published in Diabetes Care last year and presented in ADA last year. What they did was they took people with difficult to control diabetes. That means taking 3 or more anti-diabetes medications, taking 2 or more anti-hypertensive medications, and still having poor control of diabetes. And they screened for hypercortisolism looking at the 1 milligram dexamethasone suppression test, and they found that a quarter of these individuals had hypercortisolism. And of this quarter of individuals, around 35% had imaging abnormalities in the adrenals. So that was the first part of the study. And the second part of the study, they gave these individuals mifepristone, which is an antagonist of cortisol, and tried to see what happened to the HbA1c and the other metabolic parameters. They found that these individuals who were given the steroid antagonist actually had improvements in A1c, actually had improvements in body weight. Unfortunately, the treatment was not well tolerated, and around 50% of the individuals discontinued the treatment due to side effects. But again, this is food for thought, that many of these people whom you think are otherwise normal type 2 diabetes may be having subclinical defects in counter-regulatory hormone secretion. Then we have a big list of drugs that can lead to diabetes. Most of you are familiar with these drugs, but the one group of drugs which is coming up in a big way now is these anti-cancer drugs, immune checkpoint inhibitors, PI3K inhibitors, mTOR inhibitors. In fact, in this year's edition of Standards of Care in Diabetes, there's a big section devoted only to this. Because these drugs are being given very frequently by our oncology colleagues. And unfortunately, we are not aware of these, so we will not look for these things when the patient comes to you with high sugars. Antipsychotics, another common group of drugs that can cause hyperglycemia and diabetes, and this is specifically for the atypical antipsychotics, olanzapine and clozapine. The older agents like haloperidol, chlorpromazine, and the newer agents like quetiapine, aripiprazole, ziprasidone are less prone to cause hyperglycemia because they are less prone to cause weight gain. So this history also needs to be taken. Then of course we have steroid-induced diabetes. Anybody who is given steroid can have hyperglycemia. It sets in very fast. It depends on the dose, not really the duration. And it rapidly reverses on withdrawal of the drug. And this usually happens only with systemic use, only with oral or parenteral use, not with topical or inhaled steroid. And the importance about steroid-induced diabetes is that the sugars go up during the evening time. Usually, if you monitor the individual using a fasting and post-breakfast sugar, you may not be able to find any increase in the sugars at all. It goes up towards the evening, towards dinner time, after lunch, afternoon, evening, like that. So unless you monitor at that time, you will miss the hyperglycemia. And how to manage? If possible, give steroid in divided dose instead of a single dose. But that again may not be in our hands because steroid is given by somebody else, not by us. Most people with diabetes who are on steroid will need insulin. It's very difficult to control steroid-induced diabetes with OHAs or non-insulin therapies alone. And the ideal type of insulin as far as the steroid is concerned used to be the insulin detamir, which is not freely available these days. But you can still use the premix insulin or the NPH insulin, or you can give the insulin in the afternoon based on the blood glucose level. Another option that can be given is sustained release glyclazide or even glimepiride, because the peak of action corresponds to the peak of action of the steroid. And very important, once the steroid is tapered, the insulin doses should be reduced appropriately, otherwise the patient will develop hypoglycemia. Next question, are we giving the right treatment? Now we know type 2 diabetes is heterogeneous. These are the subtypes of type 2 diabetes which have been described in Scandinavian population. And we have described 4 subtypes of type 2 diabetes in the Indian population also. And these subtypes may vary in risk of complications, yes, agreed. They may vary in the ease of glycemic control, but they may also vary in the response to treatment. Studies are ongoing to see what is the cluster-specific treatment for each of these subtypes. A more simple way of stratifying treatment was published recently in Lancet. Now this is based on 9 commonly measured clinical variables, A1C, creatinine, duration, etc., etc., etc. And they use this variable to create a model to see which is the best second-line treatment to start for type 2 diabetes. 5 drugs were evaluated. They evaluated DPP-4, GLP-1, sulfonylurea, and thiazolidinediones. And they found that for each phenotype, there was one drug which is most ideal and other drugs which are not so ideal. For example, in females, they found that GLP-1 is better. Obese individual, they found that probably thiazolidinedione is better. Lean person, they found sulfonylurea is better. And they also found, by validating in a large UK cohort, that model concordant prescription, if you prescribe the drug concordant to the model, you had significantly decreased HbA1c, reduced cardiovascular outcomes, reduced risk of renal progression, and overall microvascular outcomes. Now, this is still early days. We don't know whether this approach will apply to India, but we will have to see. Finally, are there issues with adherence? If you ask patients, around 80% will say, I'm taking the medication correctly. But when you actually look at it through the refill, prescription refill, which can be done if you have a DMR, it's only around 70%. And that also I feel is overestimate. Because to be very honest, how many people actually comply with lifestyle modification? It's only around 50% at the best scenario. So isn't it stupid to assume that 100% of people are following the drugs? Maybe it's slightly better than 50%. I'm sure it is not 80%. Even we doctors feel the same. We feel that half our patients do not comply with the drug. Very simple. Somebody is given a statin and you find that LDL cholesterol is high. We know this fellow is not taking the statin irrespective of what he may be telling you. And if somebody is not taking a statin, he means he's not taking the other medication also. These are all indirect evidences that we see. And reasons for non-adherence, this is data from Africa, which is very much applicable to India also. Too many medicines, too many side effects, misunderstanding, misconception, schedule of work, etc., etc., and most importantly, the cost. So what are some of the practical ways of improving adherence? Educate the patient, follow up with reinforcement, use medical records to see which medication has worked for the patient, which medication has not worked. Simplify the treatment regimen. Luckily in India, we have all these low-cost drugs now available. We can use them and use the fixed dose combinations. Insulin errors are also very, very common. People do not suspend the insulin properly. They pull up the NPH first. They do not observe the hygiene. They inject through the clothes. There are people who inject with the cap in place. I don't know how they are able to do that, but that happens. Dial the dose and pull it out without injecting. If there is a way of making a mistake, our people will make it. You can rest assured about that. So this is a girl, obviously with type 1 diabetes who came with DK. She was saying, I am taking insulin 4 times a day. But the point here is, where is she taking the insulin? She is taking the insulin into the lipohypertrophic. You can see like a big ball it has happened. And she is injecting there because no pain, very happy. And she has ended up in DK. This is somebody with type 2 diabetes who was put on insulin following renal deterioration. Sugars was sky high with very high dose of insulin. Then we found that this guy is injecting into the lipohypertrophic site. And see what has happened to him once we made that discovery. See how his sugars have come down. So always ask that question, examine the injection site in somebody who is taking apparently very high dose of insulin without any effect. Many people do not provide basal insulin. This happens when patient is discharged from hospital after an acute event. They will just send them off on a sliding scale without any basal insulin. The opposite situation is giving too much of basal. Nowadays guidelines say start with basal. So they keep on increasing the basal without providing a prandial insulin. Reactive rather than proactive. You see high sugar and then you give high insulin, high level of dose of insulin. You don't try and find out why the glucose has gone up in the first place. Brand name confusion. U40 versus U100. Big problem in India because we have got 2 strengths and 2 syringes. I know people who take the 100 unit cartridge and pull out the insulin using the 40 unit syringe. We thought that is not possible in our country. It is possible. There are situations where that has happened. Monitoring is often suboptimal. Patient may not monitor at all. They may monitor at the wrong time. They may monitor, they may not write down the results. They will write down the results, they will not bring to the doctor. And worst situation, they bring to the doctor doesn't look at it. That is most unfortunate. Rest assured that fellow will never check his sugars again. If you don't look at it, it's not comfortable going on poking yourself. And if you don't even spend 5 seconds looking at it, why should you do it again? And people may not appreciate the dawn phenomenon and Somogyi effect. Nowadays with use of analogs and all, it has become less common, the Somogyi effect, but we have to consider that. And do not forget lifestyle factors. I think this is the most important thing, but again, this is not a fully medical aspect, it's also a psychological aspect which we need to consider. Compliance to lifestyle modification is really poor, as I said. Diet compliance is poor, physical inactivity is extremely common. 90% of our patients do not do any leisure time physical activity at all in this country. Stress and depression, low health literacy. We have this circling of patients. They start with mango season, then they go for hot season, then they go for wedding season, then they have cold season, festive season, back to mango season. This is where records will help you. Because they say this time wedding season, but last time you told me it was mango, and before that you told me it was cold season. Understand? My teacher always used to say, when you make a diagnosis, it's not what disease the patient has that is important. It is what type of patient has the disease. The same disease in 2 different people will behave in totally 2 different ways. So how do you manage? Individualize HbA1c target. There are some people, in spite of your best efforts, you cannot get to HbA1c of 7. Leave it. Maximum benefit as far as complication is concerned is obtained when you bring down the HbA1c from very high level to 8%. That 8 to 7, it is only minimally incremental. It's good if you can get it, but don't let us break our head, because otherwise what will happen, patient will say, whatever happens to me, I will not get 7, so why should I try? It's like telling a fellow who has just passed in the exam, you are not getting a state rank. So that fellow will say, I might as well fail. Why should I, whatever I try, they are not happy. Understand? So I think you should individualize in such cases. Early combination therapy, this is very important, because the longer the glucose level remains high, the more difficult it will be to subsequently bring it down. So hit hard, hit early. You will think newly diagnosed 1 metformin, you are getting to 6.7 happy. Try to get it to 6.5. At least subsequent deterioration will be slower. Use of newer agents with pleiotropic benefits, like SGLT2 inhibitor, GLP-1, we'll be having talks on that later on. And do not hesitate to start insulin if indicated. Because we are scared, if you tell the patient take insulin, they will go to some other doctor and who will say no need of insulin. If we all speak the same language, this issue will not be there. So we should start insulin whenever indicated. Multidisciplinary team approach is very, very important. Dietitian, educator, mental health professional in some cases, that is extremely important. So to conclude, a small but significant proportion of patients have difficult to control type 2 diabetes. A very small proportion have rarer form. They are rare because they are rare. Very rare. Don't think that everybody who comes to us with difficult to control diabetes has any of these secondary forms. More likely they are on therapy that is mismatched to their needs, or they are not adhering to treatment for one reason or the other. So most of these individuals can get to their individualized target with the help of a multidisciplinary care team. I'll leave you with one more quote from another of my teachers. Actually, he's my online teacher. Every well-controlled patient is alike. They do all the things correctly. But every poorly controlled patient is poorly controlled in their own way. Each person is different. And it is our job to find out in this particular person why the control is not there. Thank you for your attention.